Hi, I'm Wesley Walker of the New York Jets, former All-Pro wide receiver. You're watching Bridge to Health at Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again. Welcome back to the Bridge to Health, and my name is Dr. Tom Dow. Each week we have a guest from a different healthcare discipline who's part of our healthcare team to help you, the patient, get the best possible care that's out there. Unlike most practices, we speak with our team on a regular basis when you, the patient, comes to us and we need multiple services and multiple opinions. This week, our special guest is Dr. Andrew Herrera. Hi, Doc. Thank you for joining us.
Thanks for having me.
And you are a primary care doctor, correct?
That's correct.
Excellent. Okay, so what is your background, your education? Where did you go to school? What is your degree?
I have a degree in osteopathic medicine from the University of Des Moines in Des Moines, Iowa. I did my internship at St. Barnabas Hospital in the Bronx, and I did my family practice residency at Good Samaritan Hospital in West Islip, Long Island.
Excellent. And you practice where?
Practice in Lindenhurst.
Lindenhurst, primary care medicine.
Primary care medicine, that's correct.
Excellent. So tell us a little bit about what's the difference between family medicine and primary care medicine, or is it the same?
It's the same. There is no
Same thing.
difference.
Is it the same thing as internal medicine?
Internal medicine does not treat pediatrics, does not do gynecology, whereas primary care family medicine does.
Oh, okay. So they do a little more.
Correct.
You guys do a little more.
Correct.
Excellent. Okay. What kind of training did you have to go through to become a primary care doctor?
Well, 4 years of college, 4 years of medical school, 1 year internship, which rotates through the different fields, and 2 years of family practice that specializes in primary care.
That's what, called your residency or something?
Exactly.
Residency.
Yeah.
Okay, cool. And in your practice, I mean, what's the age groups you take care of, from what to what?
Well, I'm certified to take care of from birth all the way until death. But I like to limit
From
my
the womb
time.
to the tomb?
That's exactly what they say. Very good.
Okay. And where would you say most of your practice is? What age group?
Probably from 12 on up till, 90 geriatrics.
Excellent. What's osteopathic medicine? How does you have a DO degree,
That's
correct?
exactly right.
Doctor of Osteopathy. How does that differ from an MD degree, medical doctor degree?
Well, there's really two licenses allow you to practice medicine without any restrictions in the United States, and that's DO and MD. We pretty much go through the same training an MD does, but we differentiate ourselves by spending 3 hours a week for 2 years learning manipulative medicine, which is similar to chiropractic care in a way.
So you're actually working on spines, joints, extremities, manipulating them as part of your training, whereas a medical doctor doesn't do that.
That's right.
But you do all the same courses that the MDs do to be able to practice medicine, right?
Correct.
Excellent, excellent. Okay, do you manipulate in your own office, or do you refer out for that? What do you do?
If it's something minor, I tend to do it in my office,
Right.
but I don't really have the time to spend an hour with a patient doing manipulation. So if somebody needs something more intense like that, I refer out.
So you refer them out to somebody like me, Cairo, and another osteo for that kind of treatment. And
Therapist,
we work
correct.
together.
Exactly right.
Tell me some of the main conditions that come through your office on a daily basis.
We see everything. This time of year, we're seeing a lot of coughs, colds. The flu hasn't hit yet. I do a lot of work with diabetes. I do a lot of work with military medicine, taking care of our armed forces that are protecting us.
Were you in the military yourself?
No, I wasn't.
Okay. So what is military medicine?
That's basically taking care of the injuries that people in the military tend to sustain, a lot of concussive injuries. Nowadays, with the body armor that we have, some of the soldiers that wouldn't have survived previous conflicts make it through with a lot of extremity injuries from shrapnel projectiles, a lot of concussive injuries to the head.
So years ago, let's say World War II, we probably had a lot more deaths than we do now, and now we have a lot more survivors with major injuries because of the protection they wear now, right?
Not only the protection that they wear, but also the thinking behind military medicine is to bring the operating room forward where the troops are. This way there's less transit time to table, so to speak.
Right. I always, it always devastates me when I hear the number of injuries and the number of deaths in different wars like Iraq and Afghanistan. But what's downplayed, I think, are the injuries. They're probably 4, 5, 6 times what the deaths are.
Even more than that.
More than, okay, right, even more than that. And these are things people have to deal with the rest of their lives, and we really don't put an emphasis on that. And doctors like you are trained to take care of those injuries.
Yes.
Nice, nice. Let's talk about colds and flus, since we're getting into that season. Patient comes into your office. They got the sniffles. They got the sore throat. They're sneezing. They're coughing. And you now have to work them up and make a diagnosis and institute a treatment. What are the two main types? Tell us the difference between bacterial and viral infections.
Bacterial infections tend to be a little bit more severe, and they are treatable. Viral infections tend to be not as severe, although both can be deadly. Viral infections are very hard to treat. Usually you want to try and prevent them. That's the reason to get the flu vaccine. We really have to treat supportive care. We don't really have any good medications now, like antibiotics, that will work on viruses like the antibiotics we have that work on bacteria.
Right. So bacterial infections, is it true that people have like green mucus with that as opposed to white, or is that like a myth?
No, that's a myth. You can actually have green mucus with any infection.
Really?
Yeah, it doesn't have to be, people think green means bacteria. That's not true.
Huh.
Yeah.
Oh, that's interesting. Because most doctors I've been to over the years ask me if it's green or white and to determine if I need an antibiotic.
Yeah,
How do you determine it? How do you determine whether it's bacterial or viral and whether they need an antibiotic?
A blood test can tell you. A throat culture can tell you. Some offices do rapid testing in the office where you can get the results in a couple of hours rather than...
Well, like a strep test?
Yeah, like a rapid strep test, for example. But unfortunately, all we can do is a strep test. We can't check for other bacterial infections. Looking at the patient, bacterial infection tends to make you sicker. It also tends to give you more fever, chills, sweats, swollen tender glands.
Virals don't do that as much?
Not as much. And it's basically using the art of medicine.
So it's basically your clinical call right there.
Correct.
How often do you have patients come in where you look at them and you say, I know this is not bacterial, I know it's viral, and they say, Doc, you're not going to give me an antibiotic, please? Does that happen a lot?
It happens quite a bit, unfortunately. They think without an antibiotic, they're not going to get better.
Right.
And actually, an antibiotic can sometimes actually make them sicker.
Right.
You know, and good
antibiotics
bacteria,
are no help to viral infections,
none
right?
whatsoever. As a matter of fact, they're detrimental. You know, you've got good bacteria in the body that take up space and prevent bad things from viruses and bad bacteria from flourishing. So if you eliminate the good bacteria, you're basically putting in a move-in sign and allowing the bad stuff to take over.
Right. I explain to people, and I've done this on past shows, even with bacteria in your digestive tract, your intestinal flora, your lungs, that it's always like a battle. Here's the battlefield. Here's the good ones. Here's the bad ones. And now they're there all the time in all of us. And, I mean, most people don't realize that, but the strep bacteria, the staph, all those are in us all the time. But the good ones are what keep them in check so they don't invade and come across the line that makes us sick.
That's exactly correct.
And that's what, as I explain to people, health really comes from within. It doesn't come from outside into the body in the form of a medication or a drug. If we can keep the health within at its optimal level and keep the forces
balanced,
we keep things in check because they're in us already. And most people think, oh my God, don't come near me. I'm going to get it it's already in you.
Exactly
You
right.
need to eat well. You need to exercise. You need to take the right nutrients and supplements. You need to rest. You need to do all the right exercise, all the right things to keep those forces in check so they don't invade and take over. Am I right?
That's exactly right. 80% of people that work in hospitals, whether it's doctors or nurses, will test positive for MRSA. But that's a colonization, not an infection.
MRSA,
exactly, yep.
And they'll test positive for it.
Right, because it's only there, but it's not acting up because your own body's keeping it in check.
It's in check.
Right. And you'll take advantage of times when your body is, not in, if you don't sleep well, if
Well, you said, and then I just thought of this, and I've never thought of this before till now. Would you say that most pathogens, viruses, bacteria, whatever they are, if the body's healthy, the body can keep them in check, or there's some that are so devastating that no matter how healthy you are, you can't keep it in check?
No, that's actually not true. There is nothing really that devastating, unless you're talking about a toxin. But as far as a living organism, like a virus or a bacteria...
What about AIDS?
AIDS is also a virus, but there are plenty of cases of people that have been exposed to AIDS and not
And never become symptomatic.
That's right.
And they'll test positive for AIDS, but they keep it in check because they're healthy.
Correct.
Wow, that's pretty... we've been teaching people this in chiropractic for 100 years, that health comes from within the body and not necessarily things you put in. And you've just verified that.
Yeah, well, osteopathic medicine has the same philosophy with Andrew Taylor Still, who started osteopathic medicine.
Right? About the same time, about 1895, right?
Yeah, exactly right, in Missouri.
Yeah. Dr. Palmer and Still, about the same time. But we still did it first. Only kidding.
Yes.
Okay, so you also take care of a lot of people with diabetes in your office,
Yes,
right?
I do. I specialize in diabetology.
So explain, I know, but for the audience, explain what diabetes is.
Diabetes is a disease basically where the body has a hard time transferring sugar, which is very toxic in the bloodstream. It needs to be in the muscle to be utilized. And that's what insulin does. Insulin's like a bus. Sugar goes on board, it gets moved from the blood into the muscle, it can be utilized. If you can't get it into the muscle, then it stays in the blood, damages the eyes, vision becomes blurry, damages the kidneys, damages the nerves, damages everything. The body actually tries to help you by urinating it out. So diabetes mellitus is actually Latin for sweet urine because your urine's got sugar in it. Shouldn't have it.
And we can test that with a urine test if they're passing sugar off. We can test that with a blood test to see what their sugar levels are.
That's right.
And too low blood sugar is hypoglycemia, and too high blood sugar is hyperglycemia.
That's right.
What typically do you see in diabetes?
Hyperglycemia.
Hyper. Too much sugar in the blood because they're not pumping out enough insulin to get the sugar out of the blood, into the muscle, into the brain, into all the other parts of the body, so it's building up in the bloodstream.
Right. Another defect is their insulin that their body makes doesn't work quite as well. So they may actually have plenty of insulin, but it's not active. It's not working the way it should. And the liver, which makes sugar for us, it's called hepatogluconeogenesis. The liver is actually making too much sugar than we need to utilize.
Right. So I've heard this theory and rationale before. I want to know if it's truth or myth, what you think. I've been told that people who have bad diets, they're overweight, they don't exercise, they end up sometimes being hypoglycemic initially because the pancreas is pumping out so much insulin that eventually it's taking out too much sugar out of the blood, and after a while that pancreas has worked so hard for so long it burns out, and now it can't produce insulin anymore, so they become hyperglycemic and become diabetic. Is that a fact?
That is a fact. That is one mechanism of type 2 diabetes. Non-diabetic should be able to put out enough insulin to keep their sugar below 140 at all times. If you or I ate a bag of sugar and checked their glucose level, an hour and a half, 2 hours later, when it's at its highest, it should be below 140. If you keep doing that, though, the pancreas keeps putting out insulin, and it essentially does burn itself out. And now it can no longer do so.
Right.
Yeah.
Exactly.
And hypoglycemia is a risk factor for diabetes later in life.
Right. So this is what I tell my patients who have children all the time. It's very important when they're children that they don't overeat, they don't eat too many sweets, because they're really taxing their pancreases at a young age, where they should be eating fruits, vegetables, healthy things which can be broken down more easily, and because what they do when they're children affects their pancreas, which might affect them later on. Do you agree?
Absolutely.
Yeah. Okay, so somebody who has hypoglycemia, what are some of the symptoms they may have?
Breaking out into a sweat.
Too low blood sugar.
Yeah, breaking out into a sweat, feeling dizzy, feeling tired, getting ready to pass out. The vision may become blurry. Yeah, and the more often that happens, they develop something called hypoglycemia unawareness, where they no longer have those symptoms, and they can't tell that their sugar is low. Before it's a warning, they can do something about it, right?
Right. So when somebody has hypoglycemia, what's the best way to know if they have it? Take sugar real quick and see if they feel better? Does that help?
That does help, yes, but that's not necessarily the best way to go about things.
How would you diagnose that in your office? What would you do?
We would actually check the sugar with a machine, and it tells us exactly what their sugar is. But as far as treating it, believe it or not, milk is the best thing to do. Milk brings your sugar up, but not too high, and it tends to stay elevated, as opposed to something like orange juice or apple juice, which brings it up too high, and then it crashes back down again, 60, 90 minutes later.
Right, right. And so those of you in the audience, I want you to understand that in our offices, which are multidisciplined, when we have our healthcare team assembled, even if they're not in our offices, a doctor like Dr. Harara, who's in a remote office that we consult with, if we have a patient walk in and they have a multitude of different symptoms, they have headaches, they have dizziness, they have fatigue, that can come from a multitude of different reasons. It can come from a pinched nerve in your neck. It can come from something going on in your brain. It can come from hypoglycemia, as Dr. Harara has talked about. So we need to make sure we've gone through all the correct diagnostic workup and referred to the appropriate professionals to get their opinions so we can put all the pieces of the puzzle together and know what's best for that patient or what's combinations of treatments are best for that patient. So, Dr. Harris, so if you have a patient that now is hyperglycemic, too much sugar in their blood, does everybody always start off with injectable insulin, or are there oral medications they would start first?
Absolutely not. We wouldn't even go with oral medications right away.
What would you do?
First, we talk about a change in diet. We're talking about utilizing the sugar they have on board already. Exercise to burn off the extra sugar, raising their metabolic rate so they're burning more sugar while they're sleeping, while they're resting, watching TV. We would do a blood test to determine how bad the disease is. We're, unfortunately, in the United States, by the time a doctor tells a patient, congratulations, you now have diabetes, they've had it for an average of 10 years.
Wow.
So that's why most diabetics, when they're diagnosed, are actually being started on a medication. Because we tend to check fasting blood sugars here, which tends to delay diagnosis.
Right.
In other countries, Europe, for example, they do an A1C test on non-diabetics, and that tells them what the risk is of that patient becoming diabetic.
A1C.
Right.
So you could have a normal blood sugar, but an abnormal A1C, correct?
That's absolutely right.
Which means you're at high risk to develop diabetes.
And an A1C test basically measures the sugar coating on a red blood cell. As the red blood cell travels through the circulation, the higher the sugar level, the thicker that coating becomes. And they live for about 90 days. So by measuring the thickness of that coating, it tells us what their average sugar is in the preceding 90 days.
Wow.
Yeah.
So it gives you a history of what their diet was like the 90 days prior to that with that
Not
test.
necessarily what their diet was
but how
like.
much sugar they're eating.
Right, how much sugar is in their level. Sometimes if they have certain tumors, for example, adrenal tumors that can cause a rise in steroid levels, that can cause their sugar levels to go up even though they're not eating any sugar. We also do what's known as a glycomark. That's a test that's unfortunately very seldom used in the U.S. A glycomark tells us the range of their sugar. For example, you can have an average of 200, I can have an average of 200, but I can be between 190 and 210 all the time. You can be between 100 and 300 all the time. The same average, the same A1C, but a glycomarks would be different.
Right. So somebody comes in and you suspect diabetes, you have a positive A1C, you have normal blood sugars. Would you then maybe order a glucose tolerance test? And explain what that is.
A glucose tolerance test, we check the patient's sugar, and then we give them a sugar load. So we have their sugar before they drank the sugar load, and then we check their sugar every hour for 2 or 3 hours thereafter to see how they process that sugar.
Right.
If the sugar comes down to normal, then we know that the pancreas is putting out enough insulin. The insulin is actually working properly, and it's bringing their sugar down. If the sugar remains high, then we know that there's a problem there. Either the pancreas isn't putting out enough insulin, or the insulin isn't working properly.
And it might not be putting it out fast enough, where if you do a blood test 10 hours later, it might have had enough time, but it wasn't working fast enough.
That's right.
Right.
So that's why the numbers are done before the ingestion of the glucose load, an hour later, 2 hours later.
Right.
And if you do a 3-hour test, 3 hours later. That's usually done in pregnancy.
So I want to tell you something that happened with one of my patients. I had a patient, Eric. He was probably 275 pounds before I put him on a weight loss program. Brought him to the gym with me a couple of nights a week, put him on a great weight loss program. He lost about 65 pounds. He was a diabetic, diagnosed for 10 years before he actually started the program. He then, after losing the weight, he then went back to his doctor, primary care doctor, and he said to the doctor, I've just lost 65 pounds. I'd like to know if I could start weaning off my medications because all the levels, he still continued to take the medications, but all of his blood levels were good. So, but what the doctor told him was, no, you can't. That's why your blood levels are good. So, in other words, it's like a double-edged sword. The patient's told, you need to take this the rest of your life, even though you lost 65 pounds.
That's not necessarily true.
But what he actually did was, and I never told him this, but he did it on his own, he started weaning back the medications on his own. Very, very slowly, over months and months, until eventually he was on no medication. And he then went back to the doctor and had all his tests redone, and everything was normal. And he was no longer diagnosed as a diabetic. And the doctor said to him, see, that's because you're taking your medications. And he looked at him and said, no, I'm not.
Yeah.
Now, understand, audience, please understand, I'm not advising or recommending that anybody who's taking medication stop taking it on their own. Absolutely not. That's not the thing to do. Best thing is to consult with your physician.
Absolutely.
Let your physician in on the game plan and monitor you as you're both working together. Am I right?
Absolutely. I'm here to help my patient. I'm not there to judge them. And I'm here to help them do whatever it is that they want to try and achieve in whatever manner they want to try to achieve it, as long as it's safe and legal.
Right.
Not, it seems like Eric didn't really have the proper guidance that he should have had with
Right.
his doctor, unfortunately.
Yep.
Medicines are not permanent. Medicines, there are two main types. There are medications that prevent sugar from going up, and there are medications that bring sugar down. The ones that bring sugar down are much more dangerous. As a matter of fact, the drug most likely to put you in the hospital is insulin, followed by Coumadin, a blood thinner, and the third most likely drugs are in what we call insulin secretagogues, drugs that cause the pancreas to put out more insulin.
The most likely drug to put people in the hospital is insulin?
That's right, insulin.
Out of all drugs?
Out of all medications, insulin causes more hospitalizations.
Out of the opioids and...
Every single drug out there, from
Really?
cancer medications to strong heart medicines, seizure medicines, insulin is number one as far as causing more hospitalizations.
Wow, I never
due to
knew
its
that.
use. Yep. Yep. And then
Due to-
number three are insulin secretagogues. These are pills that cause the pancreas to put out more insulin. Because there's a high risk of sugar levels going low, and when your sugar levels are low, you become confused. Unfortunately, I had one of my patients pass away because he forgot that he'd given himself insulin
Wow.
and gave himself more insulin and more insulin. And then, unfortunately, by the time he was found, he was dead.
Is that called insulin shock?
Hypoglycemic shock.
Hypoglycemic shock.
Hypoglycemic
The brain
coma.
just doesn't have enough sugar?
There's no fuel. It's
It
like your
can't
car.
function?
You can't run your car without gas.
Wow.
And the brain only uses sugar as a fuel. It's the only fuel the brain uses. Glucose. That's why the liver has to make glucose at night. Otherwise,
Right.
we'd have a stroke every time we went to bed.
Wow.
And-
Wow. I never you would have guessed that that's the most prevalent drug
Now-
to cause hospital admissions.
It's also one of the best drugs to take when you're a diabetic. When it's
course.
used properly, diabetes is a terrible disease to have because it affects you from head to toe. But
Right.
it's also a good disease to have because if you control it, you lead a very healthy life. There are, Olympic athletes that are diabetic. NFL players that are diabetic, but they take care of themselves. They take their medication, they exercise, they eat properly.
So let's talk about your patient who passed away because he forgot that he took the injection. Now they have something where they don't have to think anymore, right? Called an insulin pump.
That's
Or
like
do
an
they still
artificial
have
pancreas.
to think? Explain what that is.
They absolutely have to think. As a matter of fact, we won't recommend an insulin pump to a patient who is not motivated, who isn't compliant, because it is a $6,000, $7,000, $8,000 device, and in a way, it's better than your own pancreas almost.
What is it? Is it something they wear?
It's
Is it
about the
something
size
they
of a
implant
pager.
inside their body? What is it?
The old ones were implanted, but we had a problem with the peritoneal catheters clogging all the time. The newer ones, you wear it like a pager. There's a little tube that attaches to the skin. It gives the insulin interstitially. When you give yourself
Interstitially, what is
in
that?
between the
Explain to me.
cells. And that's different than giving it underneath the skin. When you give yourself an insulin shot under the skin, you're going to absorb anywhere from 60 to 85% of that injection, at best. Some days it's 60, some days it's 85. That's why you can eat the same thing, yet have your sugars fluctuate.
Right. So hold on. So they're wearing this little pager device outside their body. There's got to be a tube or a catheter going in their body.
Yeah, correct.
Where does
It's
it go? Where does it go to?
It's a soft plastic catheter. It's very soft. It goes directly underneath the skin. And rather than giving the sugar under the skin, it goes a little bit deeper and gives it between the cells. So it's interstitial glucose.
Got it. A little deeper,
interstitial
so it's
insulin.
absorbed better.
The absorption is much, much better.
Okay.
Yep,
And is that
it's
so?
painless,
Uh-huh.
and it gives them continuous insulin. And when they eat, they press a button to give them a bolus of insulin, because that's what your pancreas normally does. It
So you
puts
still
out
have
a
to
little bit of
remember
insulin.
to press that button.
Yeah, you still have to press the button. Exactly. And then you also have to calculate, this is what I'm eating, this is how many carbohydrates are in there, and then you tell the pump how many carbs you're eating, and it tells you how much insulin it recommends for you to have. And you can yes it and say, yes, this is how much I'll take, or you know what, I'm going to run a little bit later, let me give myself a little bit less. If you yes it to death, you always do better than you would otherwise.
Well, I think that's great because they don't have to keep injecting themselves all the time.
Oh, absolutely.
But they still have to remember to press it and do the things they have to do.
It's very easy to do.
Has anybody developed, or is it in developmental stages of where you have that pump which is hooked up to your blood system to monitor what you have and automatically put in what you need?
Yeah, actually, it's already available. We have glucose sensors now. You can program it to keep your sugar between 70 and 110 all the time. And it will do that. And once your sugar's starting to rise, before it goes above 110, it'll give you a little warning, vibrate a little beep.
That's connected to the pump.
Connected to the pump, correct.
But you still have to press it?
Well, it tells you what your sugar is all the time. If you want to administer insulin, you absolutely have to press it. It will
Why
not.
don't they make one that'll keep it at one level and not have to press it?
They're looking into that right now, but they don't want to. The FDA does not want to take the human element out of it. Even though we have a glucose sensor, you can look at the pump and read what your glucose is all the times. We still have to do your finger sticks, to calibrate that.
Why does the FDA not want to take the human element?
I
I don't understand that.
they're
If you
being
don't
safe.
if you don't have to, I think it's safer to make the machine do it. and not have to think about it or monitor yourself.
You know, machines
If
sometimes.
your own pancreas, we don't think about it.
That's true, but our own pancreas was made by God, wasn't made by man.
Okay, so they're worried about machine error.
Yes,
Killing
correct,
somebody.
Correct. Yeah, it's always safe to have double checks, and eventually we're going to get there. Eventually we're going to have a system that's going to be automatic, and you can eat what you want, and it will take care of your sugar all the time.
Yeah, that'd be cool.
It's on the horizon.
Almost like
We're almost there now.
Almost like the Bionic Man, right? The bionic parts inside.
Yeah, instead of the $6 million man, it'll be the $6,000 man.
Yeah. So if somebody has, so we already know what the physical signs are of hypoglycemia, low blood sugar, fatigue, dizziness. You feel like you want to pass out. What are the symptoms, or are there symptoms of hyperglycemia, too much blood sugar?
Sometimes there can be no symptoms. If the sugar gradually goes up, I've had patients with sugar levels of 600 who felt okay. If the sugar rises markedly or in a short period of time, yes, you may have some of the same symptoms as low sugar. You may get weakness, fatigue, dizziness, break out into a sweat. You may have a certain fruity odor to your breath.
Okay. So if somebody has a 500-600 and they feel fine and they take the attitude, I feel all right, don't worry about it. Tell us about what can happen to the organs and other parts of the body with sugars that high over a period of time.
Glucose is extremely toxic in the bloodstream. It belongs in the tissue, in the muscle.
Right.
Yeah, in the bloodstream it's very toxic, so it will make your vision blurry. You know, a lot of my patients, if they can't read the ticker tape on CNN, they know their sugar is high.
Okay.
Yeah,
But besides making it blurry, it can cause permanent retinal damage too,
it actually
right?
causes an overgrowth of blood vessels. It's called retinopathy.
Right.
And by the time that affects your vision, it's too late to treat.
Right.
If you catch it early, that's why diabetics are recommended to see an eye doctor, have a diabetic eye exam or a dilated eye exam once a year. If they catch the overgrowth of blood vessels, they zap it with a laser and basically cure it.
But it can affect kidneys, it can affect a lot of other organs too,
Every
right?
organ, absolutely. One of the biggest complaints usually is the damage it does to the nerves. You feel like you've got like 1,000 thumbtacks in your legs all the time. Yeah, very painful. Feel like they're walking on fire.
For the audience, just to know, that's called diabetic neuropathy.
Yep.
And like you say, you feel like you're walking on glass sometimes because there's so much pain in your feet and in your legs.
And it's very difficult to treat.
Right. And we have EMG, NCV, nerve diagnostic doctors in our office where they'll do tests to see if the pain in the legs is coming from their back or their hip or if it's from a diabetic condition.
Very important to diagnose it properly in order to treat it properly.
Right. Well, Dr. Harara, thank you very much for being on the show today. It was very enlightening. And we're going to have you back on the second part 2 of the show, talking about a lot of other real interesting topics. Thank you very much.
Thank you for having me.
Appreciate it. And your office is located in
Lindenhurst.
Lindenhurst, right, okay. So, that was a fun show. For those of you watching us on Madhouse TV, stay tuned. We'll be right back. For those of you watching us on Cablevision, we'll see you next time. And remember one thing, if what you're looking for is real wealth, join us next time on The Bridge to Health. If you're watching us on Madhouse TV, stand by. We'll be right back. If you're watching us on Cablevision, we'll see you next time.
Thanks for watching.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Tracy Walker of the New York Jets, former All-Pro wide receiver. You're watching Bridge to Health at Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi, welcome back again to the Bridge to Health. My name is Dr. Tom Dow, and today's guest is Dr. Andrew Harara. Hi, Doc.
How are you, Tom?
And we had a great first show talking about many different things in your primary care family medicine practice. Today, I want you just to review again, what is a primary care doctor? What is a family medicine doctor?
That's a doctor who's trained in taking care of pediatrics, gynecology, even deliver a baby, and adult medicine.
Excellent. So our last show, we really focused on diabetes. We focused on military medicine. I want to talk a little bit about high blood pressure today, which is called hypertension for the audience to know. How common is high blood pressure in the United States?
It's the most common thing in the United States.
The most common disorder?
The most common disorder.
What is the normal blood pressure?
Normal blood pressure should be below 120. That's the pressure when the heart pumps, or at the top number, or the diastolic number. The systolic, or the second number, is the pressure when the heart relaxes. That should be below 80.
Okay, so do most people feel something when they have high blood pressure?
There are some symptoms, but there may not be any. That's why it goes under the name the silent killer. But if you're having high blood pressure, you may feel a pulsatile headache. Boom, boom, from every heartbeat. You may feel pressure at the base of your neck. You may feel dizzy. Or you may have no symptoms. You may have swelling in the feet. Having low blood pressure, you may feel weak and tired.
Right. And what are the dangers of having high blood pressure?
Well, it's kind of like having high pressure in your water pipes. Eventually, one of two things is going to happen. Either the pump is going to fail, that's a heart attack, or the pipe's going to burst, that's a stroke.
So high blood pressure could actually cause heart attacks?
Absolutely.
How does it do that? It's just too much pressure on the heart?
The heart's got to pump at higher pressure. The heart is a muscle. It's got to get bigger to do so.
Right.
It's got to work harder.
Right. So the way I explain sometimes high blood pressure to people is as people get older, they develop more cholesterol, more plaquing within their blood vessels. Instead of the hose being this wide, it now becomes this wide, and therefore the pressure in the system goes up. If you take I explained to you, you take a garden hose and you squeeze it, it's going to shoot further. It's going to have higher pressure because the inside lumen or diameter is smaller. Do you agree with that?
Yes, to a certain extent.
One reason for high blood pressure.
Well, it can also become pathological or cause a problem if it's too high. Right. There is a normal rise in blood pressure as you do get older, but the top number in somebody who's young shouldn't be above 120, and somebody who's much, much older shouldn't be above 140.
Okay. So here's another truth or myth. There are standards for pressure, norms, averages, which is what you just quoted, what the norm should be. Do you believe that there are cases, I'm going to give you an example, where those norms might not apply to certain body types and body groups?
Absolutely. Example,
you've got a bodybuilder. You've got a guy who's 250 pounds of muscle. He's 5'10". He's 5% body fat. He's ripped, and he's got a lot of mass in his body. What I found with the bodybuilders and people I take care of, generally their pressures are higher because there's more mass to pump the blood to.
Oh, actually,
is that true or not?
No, that's not true.
Okay.
If you're in good physical condition, if you're an Olympic athlete, your pressure will tend to run lower.
Right.
Your heart rate will tend to run lower. Normal heart rate is 60 to 100. Olympic athletes can have a heart rate of 28.
Yeah, no, I'm not talking about like track guys or cardiovascular guys, and I'm talking about muscle powerlifter guys.
If you're a power lifter, while you're doing the lift, yes, your pressure is going to be higher. But if you're relaxing, your pressure should be lower.
Okay.
Pressure should not be higher. Unfortunately, in powerlifting, some people tend to abuse certain medications, anabolic steroids, which tend to cause high blood pressure.
Right.
Yeah, but blood pressure should not be higher in somebody who is healthy and exercising and lifting weights.
Gotcha. So if you have a patient that comes in, cholesterol levels are great, they're good cholesterol, their HDLs are 85, 90, Their LDLs, the bad ones, are like 80. All the ratios are great. So you have a clinical idea that, hey, their vessels are okay, but they have high blood pressure. What else could cause high blood pressure?
There's essential hypertension, which means it just occurs. We don't know what causes it.
Unknown cause.
Yeah. Medications can cause it. Genetic things can cause it. Lifestyle activities. If you're angry, if you're upset, if you're in
Stress.
pain, if you're worried, your pressure's going to be higher. But if it's transient, if the pressure goes up and down, that's not so bad as if it's consistent. The pressure's up and stays up. That's much more dangerous.
Right. And the dangers of high blood pressure. Can you get any type of kidney problems from high blood pressure? Any brain problems? Any eye problems?
All of the above. Your kidney's a filter. Basically, the areas you just talked about are what we call capillary areas, or areas where arteries turn into veins and the blood vessels become much smaller.
Right.
High blood pressure actually damages those capillaries or arterioles. By driving high pressure, again, you're causing damage to the end organs, the kidneys, the lungs, the brain, the eyes, absolutely.
What are the signs of a kidney problem when somebody has high blood pressure? Are they frequently urinating? What are the signs?
Initially, there are no signs. No
signs.
symptoms whatsoever. Only later, when the damage is done, may they have signs. When you start to go through kidney failure, you're actually not urinating enough. The urine may be much more concentrated. You want your urine to look as close as possible to water.
Gotcha. Have you so obviously the first line of treatment is lifestyle.
Absolutely.
Try to decrease stress levels, try to improve nutrition, try to improve exercise. If they do all of that and the pressure is still high, then we resort to the medications, correct?
Well, that's one. No, a lot of times you can get blood pressure controlled with weight loss. Even a small amount of weight loss, a 10-pound weight loss or 5% of their body will make a big difference.
Right.
Sometimes it'll be a stronger difference than any medication I can prescribe.
Right.
Certain people are salt sensitive. If you eat salt, you find the next day your feet are swollen, you're salt sensitive. That can occur in anywhere from 10 to 20% of the population.
Right.
If you're not salt sensitive, then salt isn't a problem.
Right.
But yes, exercise. Most people don't exercise, and studies have shown at Louisiana State University, for example, that doing 5 minutes of intense aerobic activity a day can result in a 1/3 reduction of your risk for heart attack and stroke.
Wow.
That's the best 5 minutes anybody can spend.
Right.
But it's got to be daily, and it's got to be. You can't take a walk around the block. It's got to be intense.
Right.
You got to begin to
So let's say they've done all that. Let's say they're they're not overweight. They've lost 50 pounds.
They've
done all
corrected
that.
their diet.
They still have high blood pressure.
Then
What's
that's
the next?
That's the time to resort to medications.
Have you seen people that you prescribe medications for where the medications don't work?
Oh, absolutely. You have to try and fine-tune the medicine to the individual. Now, we're starting to learn more and more about that with the advent of genetic tests. But not every medication works for every person. People are unique. Some medicines work better in certain populations. Some medications work better in certain people.
Have you found that after people have been on a certain medication for a certain amount of time, that it no longer works? They adapt to it and they need something different?
Actually, that does not apply. That applies to some medications where you develop tolerance, but that doesn't happen with blood pressure medicines.
Really?
Yeah, they always continue to work. The blood pressure may have become more severe,
Then
and they require
might
more
need
medication.
A higher dose.
Higher dose or a different medicine.
Right.
Sometimes using 2 medications at a lower dose may be better and less side effect-wise and more effective than using 1 medication at a higher dose.
Right. In your practice, do you do obstetrics, gynecology, any of that, or you refer that out?
No, I no longer do obstetrics, but I do practice gynecology.
Okay, cool. Let's talk about a topic which is out there in the forefront in the news on a daily basis, medical marijuana. So there's this big controversy. New York State, I think, just recently approved the use of medical marijuana.
Effective January 1, I believe.
Effective January 1, not in the form of smoking it, but in the form of oils or vaporization or pills.
Which is smart, since smoking something is detrimental to your health.
Right. So what do you think of medical marijuana? Does it help? Does it work?
Well, marijuana contains 3 substances in there. There's THC, tetrahydrocannabinol. That's the psychoactive component. That's what makes you, quote-unquote, high. Mm-hmm. There's CBD, or carabinol, and CBN, carabinol. CBD, commonly sold as CBD oil, it's legal in all 50 states, has been. That's 40% of what's in plant marijuana, and that is the effective component. That's what helps the anxiety. That's what helps the pain. That's what helps the abdominal cramps. That's what helps arthritis, and that's currently available. People don't realize that, but
it's available.
It's currently available. It has been available. It's been
How long has it been
years.
available?
Years. It's underutilized.
hold on. I want the audience I want to get this straight. I want the audience to get this straight. So it's been available. Then why is it all over the media that now it's available? I don't understand the difference. What's going on?
Whether you want to legalize marijuana or not, that's a question for a sociologist. If you're talking about medical aspects, which is what we're here to do today, yeah, there's no reason for medical marijuana. Getting somebody high is not going to help their medical condition. But using the proper chemicals in that plant that's found nowhere else certainly can help anxiety without that high sensation.
And that's been on the market for years?
And that's been on the market for years. Marijuana has been legal since I've been practicing medicine here in New York, 21 years, as a pill. It's called Marinol. We usually tend to give it to people who are cancer patients who are unable to eat to improve their appetite. So it's been around already for over 20 years.
So I don't understand what they're talking about now legalizing it. What are they trying to legalize?
I don't understand that either, quite honestly with you.
Interesting.
If you want to legalize a drug for recreational purposes, like they did in Washington and Colorado,
that's not what New York is doing.
New York is limiting it to 20 medical conditions, basically. But that's a start. I think that's a stepping point to increase more conditions. But the benefits that patients will have from THC is not going to be any greater than the benefits that they get currently from CBD.
Okay. Have you prescribed that medication?
It is not a prescription. CBD is available over the counter without a prescription. I have recommended it for patients with good results, but they can go purchase it without a prescription.
Where? In a drugstore?
Some drugstores carry it. I've seen it recently at a gas station.
Really?
Yep. And a lot of vaping shops carry it.
Really?
It can be used as a tea. It can be used as an oil dripped right on your tongue. It can be used to a vaporizer.
Wow, and that will help arthritis and conditions like
For certain patients, absolutely. I've used it successfully for anxiety. I've used it for abdominal cramping and spasms. And yes, it has been used for pain quite well. Wow. And there are really no side effects. It's very well tolerated.
Interesting. Do you have a lot of pain patients within your practice?
No, I wouldn't say a lot. We have several, but not a lot.
Okay. And do you prescribe opioid drugs?
For the appropriate patient, absolutely. If you don't treat pain initially, you can actually make the pain worse. And
explain. How does that work?
The nerve endings become, basically, if you don't fix the pain, say somebody's got a broken leg, and you don't fix that pain, those nerve endings proliferate, and you end up with a condition that leads to more pain. And the pain can be more severe later on because you didn't use a drug for a few days early on.
That's very, very interesting. I'm sure you've heard of a condition called RSD, reflex sympathetic.
That's exactly what I'm talking about.
I was going to ask if that's what you're talking about.
Yes.
So for those of you audience who don't know what that is, RSD stands for reflex sympathetic dystrophy. That is people who have pain. It could be in an extremity, it could be in the leg, in the hand, in the foot. And there's really no positive test, like a nerve test or anything, or an MRI or anything, that can diagnose what it is. But I think what you're talking about now is this is the result of somebody who had an injury, and the pain wasn't treated properly. So now these nerve endings kind of grow like haywire.
Exactly right.
And causes long-term pain.
They proliferate.
It can cause coldness in the extremity. I mean, a whole bunch of different things, right?
Nerve pain can be very difficult to treat as opposed to muscle and bone pain.
Right.
Nerve pain actually can be treated with some anti-seizure medications. They calm down nerves in the brain so they don't convulse. They'll calm down irritated nerves so you don't get the hot, cold, gummy, tingly, burning type pain.
Right. So, truth or myth, again. So, there is a field of thought out there that when it comes to painkillers, oxycodone, Oxycontin, any of the opiates, that the brain is actually tricked by that drug. So, for instance, a patient comes in with an injury. They have a level, 0, no pain, 10, the max pain. They have a pain of, let's say, 8. They go through a course of conservative treatment. They have physical therapy, chiropractic, maybe even pain management, and they're on a course of opiate drugs during that treatment term. That when the patient starts to cut back on that medication, the brain tricks the body into thinking there's still pain there because it wants that drug again. So in other words, even if they went off the drug and their real pain now is maybe a level 5, the brain will make it seem like it's a level 8 because it's calling for that drug again. It's like almost like a rebound effect.
That's addiction.
Have you heard of that before?
Oh, yeah, absolutely. Sometimes when you're on a medication for a long period of time, and really opiates should not be used except in rare cases for long-term effects. You're basically taking the medication to make yourself feel okay. You're basically taking the medicine to prevent withdrawal symptoms, and that's
Right.
not what the medicine is for.
Right.
The medicine is designed to alleviate pain so you can be more comfortable.
And one of those withdrawal symptoms can be pain.
Absolutely.
But that
Yes.
really isn't there. It's a withdrawal symptom.
Yep.
That's pretty interesting. What about geriatrics? Do you take care of them in your practice?
Yes, I do.
And what is the most common complaint from a geriatric patient that comes through your door? Is it arthritis?
Probably.
And do you ever recommend nutritional supplements or nutritional aids for people
Yes,
with
I do.
arthritis? Such as?
I've had some success with glucosamine in chondroitin. I've had some success with SAMI. I've had some success with turmeric. Yeah, or
What is turmeric?
turmeric. It's basically a spice that is used that has anti-inflammatory effects on the body.
And they take that orally?
You take it orally. You can actually take it, cook with it,
Right.
or you can. There's pills that contain turmeric that you can use.
Interesting. And do you have patients with osteoporosis in your practice?
Absolutely.
And when they are osteoporotic, what do you do? Do you recommend nutrition? Do you recommend drugs? I mean, what do you do?
I will use any modality that will benefit my patient. We'll send them for a bone density test to see how bad the osteoporosis is.
Right.
And osteoporosis can increase the pain you get from arthritis. Depending on the level of the disease, they may require prescription medication. Now, a lot of the prescription medications that result in denser bones, they don't work unless you've got calcium in the body.
Yeah,
So
exactly.
a lot of times, the calcium is neglected. You have to take calcium in order for the medication to work. It actually takes the calcium from the blood, puts it into the bone to build stronger bone. Without the calcium, you can't do that.
Right.
You also need vitamin D. And vitamin D, there's a chronic vitamin D shortage going on in New York where we live.
Why do you think, I hear that all the time, why do you think that
Vitamin
is?
D is a fat-soluble vitamin, just like vitamins A, E, and K. It is poorly absorbed orally.
Right.
And it's not found in fruits and vegetables. Mushrooms have a small amount, but that's the only thing in the produce aisle that has vitamin D.
Mm-hmm.
The best source of vitamin D, believe it or not, are sardines, the ones with the bones in that you eat. That's the best source.
What about the sun? Don't we produce it?
Vitamin D is a vitamin. It's also a hormone, and it's the only one that the body thinks such of that it actually makes it. But it requires sun exposure, and sun exposure can lead to skin cancer.
Right.
The foods that then have vitamin D in them, like dairy foods and orange juice, which doesn't normally contain vitamin D, but it's fortified. They add it in. You still have the absorption problem.
Right.
It's still not absorbed well. That's why they have things on the market now that result in sublingual administration. So it's a tablet that you suck on or a liquid that you put on your tongue, and it's absorbed much, much better.
Calcium, vitamin D, and magnesium is important too.
Magnesium and phosphorus are also important, correct?
I counsel my patients on nutritional supplementation for osteoporosis. And the way I explain it to them is that they ask, well, do I really need it? I'm just borderline normal, not even osteopenic yet. They might be 55, 60 years old. And the way I counsel them is, yes, you need it now. I explain to them calcium, you store it. It's like a bank in your body. I'd rather see you at the higher level of normal now. And then as you age, as it comes down, instead of being osteoporotic, you might just be going into osteopenia. So I also recommend it whether they're osteoporotic or not at certain age groups, especially if they're on the low norms.
40 and above. It's a blanket recommendation for women, 50 and above for men.
Right. I've had other guests on here that say you don't need any nutritional supplements. All you got to do is eat well. What do you think of that?
Well, that actually may be true in certain situations. If you are getting 8 servings in different colors of fruits and vegetables, and your body's absorbing it properly, yeah, there may may not be any need for nutritional supplementation. But quite honestly, that's difficult to do, and very few people do that. And that's assuming that the absorption is there also.
It's difficult to do also because the soils we grow our foods in this year are depleted of nutrients and vitamins. Cooking takes out a lot of the vitamins that we do unless you want to eat it raw. So I explain to my patients, you know what? As long as it's not going to hurt you, supplement just in case you're not getting what you need.
Sometimes the best part of the food is the part we throw out.
Right.
If you eat kiwis, it's the skin that's the most beneficial.
Right. And most people don't realize that when they look at a vitamin and they look at what are called the RDAs, the recommended daily allowances, those amounts that they put on there are the amounts you need to not become ill.
Minimum amounts.
Right. They're not the amounts you need to stay healthy. And so when somebody says, "Oh, I'm taking a I'm not going to mention the name, but a common one that's bought over in the drugstores or over the food stores, and they say, well, I'm taking 200 milligrams of vitamin C. It says that's our recommended daily allowance. Why would I want to take more? I say, because if you take less, you're going to get scurvy and you're going to end up becoming ill. It's better to have more. So again,
To a certain degree.
is within the body. Yeah, not overdose on it. I mean, that's a water-soluble vitamin. It's pretty hard to overdose on that one.
Well, too much of that can actually acidify the urine, which can lead to kidney stones.
Yeah, that is true. But what else? What other kinds of things do you do in your practice? Do you do surgery in there?
Yes, we do minor surgery. We remove skin lesions. We suture lacerations. We do cryosurgery. We do suturing with staples as well.
How about crazy glue? I heard they can sometimes close wounds with crazy glue. Is that true?
Absolutely true. Cyanoacrylate glue, the only difference between the medical version, which is purple, and the regular version, which is clear, is sterilized. That's it. But it's the same exact glue. We also will use hair. You know, if you've got a scalp laceration, I'll take about 8 individual hairs, twirl them together, and use that to suture the wound closed. Yeah.
Are you kidding?
No, absolutely
I've
right.
never heard of that before.
Yeah, why cause additional trauma to the area by putting an additional hole on each side of the wound to use foreign matter to close it when you've got your own hair there? Provided it's long enough, it works great.
So hold on. So somebody's got a cut on their head. Instead of putting holes and suturing, you'll take the hairs, pull the skin together, and then tie the hairs together?
And tie the hairs together to close the wound. Absolutely. It's a very common technique. It's done by many, many physicians.
I've never heard of that before. That's awesome. Yeah, because you're not putting anything into the wound.
Correct.
There's a condition that I've seen a few times in my office called cellulitis. I'm sure you've seen that in your practice, right?
Yes.
Can you explain what that is to the audience?
Cellulitis is an infection of the skin. The skin is your largest organ. It's very important. It differentiates between what's outside and what's inside. Your body's supposed to be sterile. The body's like a donut. The mouth to the rectum is a donut hole. The donut tissue should be sterile. When you violate the skin, you develop a portal of entry, which can allow bacteria, other infectious agents in, which can lead to problems. So cellulitis can be a serious infection. It can result in loss of limb, loss of life if it's not treated urgently. A lot of times, cases people are hospitalized to get IV antibiotics for this. If it's caught early, it can be treated with over-the-counter medications prescription medications. But that needs to be done early. It results in redness, pain, fever. About the 4 cardinal signs of cellulitis: heat, pain, fever, and swelling.
So I explain to my patients that the best way to suspect that you might have cellulitis is if you've got almost like a bordered area. Your skin's red, and there's a border between the red and the white. It can be round. It can be any shape on any part of your skin, on any part of your body, correct?
Correct.
It's
Anywhere
more common on the lower extremities, though, right?
That's because there's less perfusion, less blood supply down there.
Okay. And if you see anything red and you touch it and it's hot, that's a pretty good indication you might have cellulitis, right?
Painful.
Right. And so if that happens, what's the treatment for that? What do we do?
Treatment is antibiotics. If it's bacterial cause, you want to put them on the proper antibiotics. If you know what did it, if it was a dog bite, if it was a scratch, then you can tailor the antibiotics appropriately. Right. If you're not sure what did it, you may be forced to use broad-spectrum antibiotics, basically a shotgun approach rather than a sniper rifle.
I just recently had cellulitis in my left foot.
Oh, I'm sorry to hear that.
I was taking a plate off the kitchen counter, slipped out of my hand, went down, broke on top of my foot, caused a small little puncture hole. Nothing big. I mean,
That's all you need.
I put a gauze on there. I did a compression bandage on it, washed it out a little bit. 2 days later, I see my foot's starting to get red. It's getting bigger and bigger and bigger and hot. Right to the hospital, IV antibiotics. They actually had to open it up and then put a drain in to let it drain because it was infected. But it cleared up okay, but it can be.
It was painful.
Very, very painful. I've had patients come in where it starts off as a little red spot like this big, and then overnight it just goes right up the leg. It can advance very rapidly,
Absolutely.
right?
And then it's called lymphangitis when you start to see red streaks. And you mentioned in your case you had a puncture wound. Puncture wound is actually a lot worse. It may be a smaller wound, very tiny, but the bacteria is deposited in much deeper.
Yes.
As opposed to a laceration, it may be a much bigger wound, but it's on the surface.
Right.
Hydrogen peroxide always, if there's any wound, but you only use it once. I have patients that will use hydrogen peroxide over and over again without realizing that delays the healing process. Hydrogen peroxide is so potent it actually destroys the cells that are starting to heal.
Really?
Yeah, so you only use it once on a wound to sterilize.
Wow, one
And
time.
wounds should always be kept covered, and they should always be kept moist. Wounds heal better when they're moist. There's actually electrical charges that are sent between the cells. Electricity travels better in a moist environment than in a dry environment.
Again, an old myth. My mom and dad used to say, don't keep it moist, let it scab. When it scabs over, it's healing.
Yeah. Leave the scab alone. That's nature's Band-Aid.
Right.
Don't pick off a scab. Eventually, it will fall off on its own. You'll find the skin underneath perfectly brand new and healed.
Right. Has anybody ever died from cellulitis?
Oh, absolutely.
Yeah.
Unfortunately, many people, thousands of people die of cellulitis.
And what kills them? It just spreads into their whole body?
It overwhelms their body. They become septic shock is the ultimate cause of death, and they're unable to maintain their blood pressure. So their heart basically fails. You develop multi-organ failure.
Wow, wow.
Some bacteria, they're toxic in and of themselves. Some bacteria release a toxin. Everybody's familiar with botulism.
Yep.
Botulinum, that's the bacteria is not what does the damage, it's the toxin that it releases.
Right. What do you think of people who go for this facial work, like the Juvederm injections, the botulism, what do they call it, Botox,
Botox.
injections? Is that dangerous to the body, do you think?
Oh, it certainly can be. I mean, there's a big difference between, plastic reconstructive surgery and cosmetic surgery. With reconstructive surgery, you've got somebody who has a medical problem, legitimate problem needs to be addressed. With cosmetic surgery, you've got a healthy patient who wants to be better in some way.
Better looking cosmetically.
Whichever way, but they're not diseased.
Right.
They're healthy.
Right.
Now they're undergoing a procedure that has risk factors, and the risk factors, if there's any cutting involved or anything injected, can lead to an infection, which can lead to sepsis.
Right.
So yes, they put in.
Well, I guess what I'm getting at, though, I mean, botulism toxin is extremely deadly to the body. Is there?
In small amounts, actually, it can be beneficial.
Oh, really?
Yeah, absolutely. It prevents spasm. So some people can have severe pain due to trigeminal neuralgia, for example. They can have sweaty palms to the ability where it affects their job. They're unable to shake hands.
Right.
So with Botox injections, it actually alleviates that. It's not permanent. They have to continue the process either every 3 months, every 4 months.
Doing the right amount and the right dose.
Exactly.
Right.
There's the right dose determines the difference between a toxin and a therapy.
Right. So, for those of you in the audience, I just want to make one thing very clear is that when we have our guests on each week, we touch on a different discipline and a different topic. But remember, things like Botox injections in muscles and things like that, this is not our first line of approach. Our first line of approach always with all of our patients is conservative treatment first. We'll try things like chiropractic, we'll try massage, we'll try acupuncture, we'll try natural healing methods, even nutrition, and things to help treat the spasm, treat the whatever the symptoms are first. And then as we go along, if we need the additional help and things are not progressing the way we want, we may go to other modalities, such as the ones we've talked about, and eventually, unfortunately, sometimes even surgery, but always the most conservative, non-invasive methods first. And thank God, knock on wood, most patients respond, with those conservative modalities. But
First,
again,
do no harm.
First, do no harm. Thank you very much for being with us. Again, you're in
My pleasure.
primary care doctor in Lindenhurst, Dr. Andrew Harara. Thank you very much for being on our show, and we'll have you back again. Really enjoyed it.
I hope so. Thank you.
And for those of you watching us on Madhouse TV, remember one thing. Or if you're watching us on Cablevision Channel 20, if what you're interested in is real wealth, make sure you join us next time on The Bridge to Health. If you're watching us on Madhouse TV, stand by. We'll be right back. If you're watching us on Cablevision, we'll see you next time.
Thanks for watching.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.